Hello, my name is Simona Bhattacharya, and I'm the Advanced Inflammatory Bowel Disease Fellow at NYU. I'll be speaking today along with Dr. Adam Fay on the topic of post-hospitalization venous thromboembolism risk in patients with inflammatory bowel disease, or IBD. Venous thromboembolism, or VTE, is a well-known complication of IBD and carries significant comorbidity and mortality. Over 500,000 hospitalizations each year in the US are attributed to VTE, consisting of DVT and PE. Annual costs are estimated at $20 billion. VTE can lead to significant morbidity and mortality, and thus prevention of such events is key. Patients with IBD are at notably higher risk for VTE as compared to those without. In part, this is driven by periods of ongoing inflammation, restricted mobility as in post-surgical intervention, and/or ongoing corticosteroid use. These are just a few of the risk factors. The first article I will be presenting is seen here and was published in CGH in May 2020. In this study, Dr. Fay and colleagues utilized the nationwide readmission database to evaluate the risk factors and timeline that led to a VTE readmission after initial hospital discharge among patients with IBD. Between 2010 and 2014, there were over 800,000 IBD-related hospitalizations, with 1,160 resulting in readmission for VTE. Shown here, the risk of readmission was highest immediately after discharge and then decreased over time, with 91% of readmissions occurring within 60 days. Major risk factors for readmission included history of VTE, longer index hospitalization, presence of comorbidities, flexible sigmoidoscopy or colonoscopy during index admission, which was used as a surrogate marker for a disease flare, and age over 18 years old. Additional risk factors included C. difficile colitis diagnosis during index admission, discharge to a skilled nursing facility or intermediate care facility, and discharge with home health services, which likely indicated restricted mobility. The second article we will be discussing was published in Inflammatory Bowel Diseases in September 2021. It looked to examine the cost effectiveness of 1 month of VTE prophylaxis after hospitalization in patients with IBD. In order to assess this, a decision tree model, shown here, was built. It compared no outpatient VTE prophylaxis with outpatient VTE prophylaxis for 4 weeks after discharge. It included elements such as bleeding risk and risk of post-thrombotic syndrome. The primary analysis was performed using 10 milligrams a day of rivaroxaban. VTE-related costs and outcomes were modeled for 1 year. From the results, extended prophylaxis after hospitalization was found to prevent 1 case of post-discharge VTE among 78 patients. This resulted in 1.68 higher quality-adjusted life years, or QALYs, per 1,000 persons at an incremental cost of $185,000 per QALY. The authors concluded that post-hospitalization VTE prophylaxis for all patients with IBD admitted to the hospital was not cost-effective based on a threshold of $100,000 per QALY. On sensitivity analysis shown here, the model was most sensitive to the probability of VTE, seen in the top bar, and the cost of drug, seen in the second bar, with other relevant variables listed. Thus, as the risk of VTE increases or cost of drug decreases, extended pharmacologic prophylaxis becomes cost-effective. Given these findings, the authors concluded that post-discharge VTE prophylaxis was not cost-effective for all patients with IBD who were hospitalized, but rather should be considered on an individualized basis. For instance, patients who have multiple risk factors for VTE, including older age, recent surgical intervention, corticosteroid, oral contraceptive, or tofacitinib use, those with a history of prior VTE, who are postpartum, who have restricted mobility, or are experiencing an IBD flare can be considered for extended duration pharmacologic prophylaxis. Thank you for your attention. Dr. Fay will be speaking next.